I'm going to get started. Good afternoon or good morning if you're one of our friends on the West Coast. Thank you for joining today's webinar, Actionable Research on COVID-19 and Homelessness. My name is Joy Moses, and I am the director of the Alliance's Homelessness Research Institute. Today, we will be focusing on data and research evidence related to the current crisis. Across the country, people experiencing homelessness have been participating in COVID-19 testing. Vaccination plans are underway based on what is known about our clientele. And as our communities decide whether to take advantage of a 100% reimbursement from FEMA for their hotel motel programs, they can be informed by research focused on those programs' effectiveness. What we know matters, as well as what we still need to learn. Driving this discussion is an excellent panel of speakers today. We have Margot Kushel from UCSF's Benioff Homelessness and Housing Initiative, Hugo Aguas and Lauryn Berner of the National Healthcare for the Homeless Council, and Rachel Fyall of the University of Washington. Before we start, I would encourage you to ask questions throughout the session using the Q&A box on your screen. The chat function is also available for conversation and information sharing among attendees. And with that, I think we'll begin the discussion and I will turn the floor over to Margot Kushel from the Benioff Homelessness and Housing Initiative. Margot?
Wonderful, thank you. Let me just share my screen. Oops, go back here. Hi everyone, my name is Margot Kushel, and I'm going to talk a little bit about what we've learned through COVID-19 testing and learned about vaccinations and vaccination concerns and hopes from people experiencing homelessness in the Bay Area. I'm going to talk about some work we've done testing unsheltered populations, talk about our pilot initiative now in all shelters in San Francisco conducting rapid COVID testing twice weekly, and talk about lessons learned about vaccinations. So we have conducted 2 large-scale testing events in June and October of 2020, conducting in the two districts in San Francisco with the largest numbers of people experiencing unsheltered homelessness. We tested almost 1,000 people, and we found a surprisingly low prevalence of PCR positivity or evidence of active infection, as well as a relatively low prevalence of antibody testing showing past infection. We found what we think more importantly were the lessons learned about how to reach this population and frankly the implications for vaccination. We worked very closely in collaboration with the community and the San Francisco Department of Public Health. We formed a community advisory board in each district, which had quite distinct needs and interests. Worked with several community-based organizations. We stipended and hired and trained community health outreach workers, people with lived expertise of homelessness, who became our COVID experts and went out into the community the week before each event, educating people about COVID, the necessity of testing, answering questions, and dispelling any myths. While our first testing event had a main pop-up site in front of a major service organization with a barbecue, food, veterinary services, the ability to get stimulus checks, signs up and other things like that, we quickly found that what was much more important was that we went into the field and we took on the spot a mobile model, and each participant got a cloth mask, food, and a gift card for their participation. When we did our mobile testing in our second event, we flipped it and we did primarily mobile with a little bit of a pop-up sense. We sent our teams into the community, onto street corners, into encampments, wherever we found people. Each team was led by the chow, who was empowered to lead the group entirely and had full discretion. A medical technician or a phlebotomist who did the swabbing, and we were doing blood draws for antibody tests. Interviewers who went with mobile hotspots and tablets to get information from people about their health, their healthcare needs, their attitudes towards vaccination, as well as any exposure risk and things like that. And each team had an embedded nurse, nurse practitioner, physician, either with them or nearby who could help because we found many people with serious health needs. We found that the mobile testing, frankly, worked a lot better than the pop-up models, even though they were often only a few blocks away. One of the things that one of our participants told us was this was about the coolest thing I've ever seen. You just showed up right up on the spot testing on the sidewalk. It was just a good idea. And the main facilitators that we heard from participants was the use of the community health outreach workers, the fact that we were mobile, and the $10 gift card. Some barriers, which I think also have implication not only for testing, but for vaccinations. We heard widespread concerns that people could catch COVID from the tests, and a concern about unintended consequences, or the way that we actually punish people for, as a participant said, doing the right thing. They noted that if they had tested positive, they would not be allowed back in their sanctioned encampment, or they feared that they would lose their spot, which was a real fear. I would not be allowed back if I tested COVID positive. If you disappear from the encampment, then there's a good reason as to why you're disappearing. Why did he go? He left all his stuff. He must have COVID. Even the staff working at the sanctioned encampment, they would be like, he had that COVID, and I don't know if we want to let him back in here. I feel like even if I went into isolation, which were these hotels that we use in San Francisco to provide people quarantine and isolation, and didn't have COVID anymore, that would happen. So like, just to be on the safe flight, it's like the backlash from doing the right thing. It's going to have a serious effect on me. We realize that, shelters are actually where the action is at, where there's a lot more infection and a lot more risk. And we wanted to improve the accessibility and availability for testing for people experiencing homelessness and staff working in shelters who previously had only had access to testing about once a month, if that. We wanted to be able to rapidly detect and isolate people who were infectious to prevent COVID-19 transmission in the congregate setting. And we wanted to perform implementation evaluation of rapid testing to inform other jurisdictions. We really wanted to create a model that could be used. UCSF partnered with the Department of Public Health and our Department of Homelessness and Supportive Housing and Kaiser Community Benefits, which is helping us to develop a toolkit, which we hope to have out by next week so that anyone can do this. We used a new low-cost rapid test by Now, which costs about $1 a test as opposed to about $100 for a PCR test. This has an emergency authorization use for symptomatic screening, but another collaborators at UCSF showed that it had very good testing characteristics for COVID if people had enough viral load to actually be infectious. So it misses people in the first day or two of the disease, but once people get to the point of the disease where they can transmit it to others, it's actually very good at picking it up. Because of that, we wanted to do twice weekly testing because of frequent testing actually can really get people out to safety so that they can be safe and those around them can be. We offered an incentive structure based on recurrent testing. So if people test a certain number of times over the course of a month, they get a $20 gift card. Since January 2021, we've administered now well over 2,000 tests, including 300 unique shelter guests and 200 shelter staff. And our current workflow, which we've sort of tried to get it down to the fewest people possible in order to allow for spread, is we have stipended and trained a shelter champion, someone who works in the shelter, who we've given lots of education and resources about COVID. They are in charge of handling communication to residents, developing messaging, plans, and manages our workflow, and they assist with getting us people to isolation and quarantine if they're infected. People register. We have a non-clinical staff member sitting with a tablet with a portable Wi-Fi to get the information that our state requires of everyone who is tested. People self-swab while they're registering, basically. And then we have two people, usually a nurse and a health worker, who read the test. And then if they're infected, we have a floating nurse on site who does a few things. Anyone who's positive, they go and find, they talk to them, they arrange for transport to isolation and quarantine. And importantly, because we ask everyone in the registration or in the check-in if they have any symptoms, we found that it's important to have a nurse evaluate whether we would consider those symptoms to truly be symptoms of COVID, because many people experiencing homelessness daily have symptoms that otherwise are thought of as COVID symptoms, but actually aren't likely to be COVID. When we detect someone who is infected, we contact them immediately. We do contact tracing right there on site in the moment. We inform the shelter if they have positive cases, because the shelter actually changes their protocols if there have been positive cases. The outbreak team communicates to stakeholders and provides leadership with a building notification to put up to let others know. And if they're more than 2 positive or 1 positive and 1 person with symptoms who is negative, who we also remove, we stop admissions at that point to the shelter. We have found a relatively low rate of positivity. About 1% of tests come back positive. We've had a moderate rate of false positives. We've had 2 false positive tests over the course of the testing where their Binax test was positive, but a PCR test showed that they did not have an infection. The successes we think are the strong partnerships with shelter staff and leadership, the use of non-medical staff, a real multidisciplinary effort. And we were able to we started with a much more robust staffing, and we've peeled staffing back with the hopes of making this something that other jurisdictions can take on. I will tell you that we have used our outbreak team as part of the testing, so it's now 1 team. We have identified outbreaks and cases at 2 shelter sites where outbreaks were identified. There have been no new cases, signaling effective outbreak identification and prevention. Identified and isolated infectious individuals. We've had very high participation rates. We've incorporated our outbreak management team, and it's been highly acceptable to participants who noted the convenience and the incentives as important parts. Secondary, we are going to lay our vaccination plan in shelters on top of this team. This team has gained the trust of the community members, and they are doing vaccine education. And as soon as we can get our hands on vaccine, we will use this team to help assist to vaccinate both guests and staff who wish to in the shelter. And finally, for vaccination, in our mobile testing, which we did in October, before all the studies that showed how successful the vaccines were, before the vaccines were approved, 70% of people who were tested were very or somewhat willing to receive the COVID-19 vaccine. This was higher than the US population at the time. Do not believe this word that people who are homeless don't want to be vaccinated. It isn't really supported by the evidence. This was only amongst those who agreed to COVID testing, so maybe those who didn't agree would be less likely. On the other hand, most people who we showed up for agreed to COVID testing. People reported their motivations for vaccination, primarily family reunification. People wanted to see their loved ones again, and a sense of civic responsibility. We got to get this epidemic handled. If they come up with a vaccine that actually works, I think everyone should get it because we've got to get rid of this. You can't have some people getting a vaccine, then you're missing people. Everyone's got to have it if we want to get rid of this. I think that's the biggest challenge. How are you going to get everyone vaccines? Some considerations. People repeatedly mentioned that they didn't want to be among the first, and they really wanted to do their own research. They wanted access to high quality data that this worked. It'd probably take actually time for me to agree to get vaccinated because that's the only really way you can see if something works or not. And I would have to know people that did it for me to maybe trust it, because you can't believe everything that they, mainly the government, say. People really wanted trusted mediators who they knew had gotten vaccines. Some concerns that came up, once again, we heard concerns that vaccine causes disease. I will tell you this is very common for all vaccines, and people pointed to, well, I got the flu shot and then I got sick. I think this is an important thing to keep in mind, as we know these vaccines can cause side effects that mimic COVID, very mild COVID. Mistrust of government, we heard again and again, and experience of medical racism that I think we need to grapple with and own as a medical system, that we have not earned the trust of Black and Brown communities in this country. I'm a Black person, and I'm kind of skeptical about being among the first to get the vaccine, because as ethical as they sound and as transparent as they're supposed to be, and all of this stuff, I know that the CDC and the medical department, they've been known to experiment on people. So to give you my honest view, I wouldn't take the cure unless I saw someone like Donald Trump and some of the other people taking it. So some key lessons here. We believe that the mobile approach is absolutely ideal. We need to do vaccines where people are, whether that's in shelters or in encampments or on street corners. Trusted community members are absolutely crucial. We need to hire, pay, support, train members of the community to be our leads on this. They are the ones who should be in charge, and we should follow their lead and have them lead the conversations. We need to develop and sustain partnerships. Our CHOWs began outreach long before, CHOWs should begin outreach long before vaccinations, and we should not be squeamish about using incentive. We heard that again and again and again, that incentives would help people to agree to get vaccinated. The use of the newly approved J&J vaccine will reduce the need for a second vaccine. But if we're gonna do one of the other vaccines, we need to plan for the second vaccine. We need to perhaps increase an incentive to get your second vaccine. We need to collect excellent contact information and really use our chows. And finally, we need to be honest, as anyone who's been lucky enough to get a vaccine will know, is that there are side effects of this vaccine. That's a great sign that your immune system is working, but we can't pretend that it doesn't exist. And we need to talk people to and explain it so that we don't frighten people. And frankly, if people are unsheltered, we need to provide a safe place where people can get the care that they need if they experience a fever or other side effects of the vaccine. Mobile testing and vaccinations are key. They must be accessible. Using community health outreach workers is necessary, both as trusted community members who can dispel myths, and it is possible to prevent outbreaks in high-risk settings with repeated testing, and I can't say enough, place-based vaccination. And with that, I'm going to stop and turn it over to my colleagues.
Thank you, Margot. So I'm going to turn the floor over now to our friends from Healthcare for the National Healthcare for the Homeless Council. And they're going to do an overview of what's been going on across the nation in communities like San Francisco, but obviously also beyond. So I'm going to turn the floor to them, over to them.
Great. Thanks so much, Joy, and thank you, Margot. And thank you to all of you who are joining us today. I'm Lauryn Berner. I'm the research manager at the National Healthcare for the Homeless Council, and I am joined by my colleague, Hugo Aguas, who's our research associate. And we're going to briefly talk about two of the dashboards that we have available on our website that might be just useful information for you. If you're unfamiliar with the Council, we're a membership organization. Our mission is to build an equitable, high-quality healthcare system through training, research, and advocacy in the movement to end homelessness. So the two dashboards we're going to talk about today have data from different settings. One focuses on clinic-based data from Healthcare for the Homeless programs and health center program grantees more broadly. We're going to focus on the Healthcare for the Homeless program. The other that I'm going to quickly touch on focuses on community-based universal testing events at homeless service sites, which actually includes some of the data that Margot talked about in some of their testing events. Again, we'll spend most of our time discussing some of the clinic-based data because we have a little bit more of that. But the Health Resources and Services Administration, or HRSA, which funds the health center program, surveys health centers weekly. Our first survey related to COVID came out the first week of April. So we've got a decent amount of information now. And our dashboard is updated monthly. Typically between about 900 and 1,100 health centers report each week out of a total 1,400. About 200 of those reporting weekly are Healthcare for the Homeless program. The survey that they're receiving has questions on testing capacity and clinic capacity, as well as testing and positivity by race and ethnicity. And with the new year, we've started receiving some information on vaccine initiation and completion, and we're excited for Hugo to share some of that information with you in a little bit. The community-based dashboard looks at universal testing and vaccination events at homeless service sites. This is a partnership with the CDC, and we launched a survey back in May to collect this information. It looks at reasons for testing, types of facility where events are held. A lot of these are sites that are funded by local COCs. We look at demographic information. This information is not super robust, but what we have seen with the information that we have is that this population that we're seeing coming through in the community-based testing is different from that of the clinic-based testing. The survey is also retrospective. So if your community, someone you know has held a universal testing event or a vaccination event, we would love your input and love to hear from you so we can add that to the list of things that we have. Our colleague, Joey Kenkel, is keeping this up to date for us, and we just received the first set of vaccination information for this too, so you can check the website for some of that coming out hopefully soon. Just to highlight a few things that we have from the universal testing events in the community is we have about 400 testing events submitted as of pulling this information. That represented over 13,000 clients tested and over 3,000 staff tested. We do see that there's a higher positivity rate for clients than staff, about a little over 7% for clients and over 3% for staff. And we also looked into the presence of symptoms in those who tested positive. Again, this survey came out in May, so kind of early on, we weren't sure what the prevalence of asymptomatic cases were going to be like. And so what we did see is that among clients at homeless service sites, about 70% of those who tested positive were asymptomatic. As I mentioned, we looked at the reason for testing and the facility type, and we were happy to see that most of the testing was proactive, and testing that was held proactively had about a 2.7 positivity rate for folks who were tested at that event. The highest positivity rate was 19% for sites that tested in response to 2 or more confirmed cases. So testing proactively really helped to reduce some of those cases and identify it early, which could really help to prevent future outbreaks in that community. Most of the reporting facilities fall into multiple shelter categories. Maybe you're a drop-in shelter and also have transitional housing, or a day center. So kind of falling into those different buckets. When we break this out further, we did see that most identified as a drop-in shelter. At drop-in shelters, there was about a 7.6% positivity rate. And the highest rate was actually seen among inpatient drug and alcohol rehabilitation facilities, where it was about 23% positivity. I think that it's really important to pause and just reiterate the importance of the community-based approaches here, echoing what Margot said. Meeting folks where they are, being proactive in our testing efforts, and really kind of partnering with your local health departments and meeting folks where they're at. At this point, we're going to transition over to some of our clinic-based data, but I want to give a little bit of a refresher on what we're comparing to, because I think we have a tendency to compare our data to the national population, which is not always the best way to make sure that we're being equitable in our distribution of testing and vaccinations. So we're looking at health disparities, and we really need to look at the disparities within the homeless population in the US, which in 2019 was over 560,000 folks, according to the HUD AHR report. And when we're looking at some of the demographic breakdown, we see that about 22% of folks experiencing homelessness identified as Hispanic or Latino, and 40% identified as Black or African American. When we look at the US population, that 22% is a little higher than the US population, which is about 18 to 19% Hispanic or Latino, and 13% Black or African American. So we see a really large disparity here. So when we're looking at our testing rates by race and ethnicity and our vaccination rates by race and ethnicity, we need to make sure that we're offering it to everyone and not necessarily comparing it to this 13% number, which is really easy to do because those tend to be the numbers that we see when we're looking at the news or more generalized reports in the US Census and things like that. So just want to make sure that we're reaching the right folks. And I'm going to hand it over to Hugo to talk about, kind of in light of this, how does our testing efforts look?
Thank you so much, Lauryn, for the introduction. As Lauryn has already stated, this data actually comes from our health centers that receive 330H funding, meaning they assist people who are experiencing homelessness. For the past year, they've been sending us data on testing, positivity rates, antibody testing, and more recently, vaccination data. This data set that you're going to be seeing was last updated on January 29th, since it is updated monthly. And as of that point, 2.6 million patients experiencing homelessness have been tested, and thus far 315,000 have tested positive. In this first slide, you'll be able to clearly see a differentiation in between testing Hispanic and non-Hispanic whites. 855,000 Hispanics have been tested for COVID-19, and 155,000 of them actually came back positive. This meant that nearly 1 in 5 Hispanics tested at our sites were actually tested positive for COVID-19, while non-Hispanic whites, nearly 1.3 million individuals were tested and 107,000 came back positive. This accounted for 8.34% of all non-Hispanics whites tested positive. compared to nearly the 20% of Hispanics. When considering race, the average positivity rate per racial group actually accounted for about 12.05%. Whites were the most tested racial group. Whites had 1.2 million tests administered, with 7.89% of them being positive, for about 121,000. The next largest group were African Americans, and we tested 460,000 African Americans. 45,000 of them actually returned back positive, and they had a positivity rate of about 10%, which is still higher than their white counterparts. But some of the most interesting findings from this data involves groups that were least tested. Specifically speaking, Native Hawaiians and Pacific Islanders, they had the highest positivity rates in our analysis per racial group. Out of the 4,227 Hawaiians that were tested, 662 of them returned back positive, which is nearly 16% of the population that was tested came back positive. And in regards to Pacific Islanders, about 11,000 Pacific Islanders were tested, and 1,600 of them were positive, which also came back really high at about 15%. Finally, 101,000 multiracial individuals were tested, and about 14,000 came back positive, all at about over 10%. This one actually came back at nearly 14% back positive.
Thanks so much, Hugo. I'm going to jump back in for a little bit more framing before we move into some of the vaccine data that we've received, just to provide a little bit of framing. So these charts up here are adapted from some of the work that the Kaiser Family Foundation has done. I highly recommend this resource. It's really great in kind of showing where folks are currently in their vaccine rollout, and also which phase prioritizes people in congregate settings. I pulled this information on Friday, and it looks like they updated it yesterday, so there may be a little bit of a change with where states are in the last couple of days. So please check that out if you want a little bit more up-to-date information. What they found is that about 30 states and DC have a vaccine rollout plan that specifically includes language that prioritizes people living in congregate settings. A few of those do define congregate settings in ways that do not necessarily include people experiencing homelessness. So that's what's depicted in the map on the left. There are also differences in kind of what phase folks are prioritized in, but of those that kind of explicitly outline it, we see that most of those are in phase 1B. On the right, you can see as of the 22nd of February, the current phase of vaccination rollout. It looks like a couple of more states have moved into phase 1C since I've pulled this, but for a general idea, most folks are in that phase 1B. So what does that mean when we're thinking about access for people experiencing homelessness to the vaccine? It looks a little bit more like the map on the left here. We see that a smattering of states have entered the phase where they are explicitly prioritizing people experiencing homelessness for vaccine eligibility, again, as of last week. When Hugo starts to share some of our data that we have on vaccination, that's going to represent all the states on the right. And that is a much larger number of states that are reporting vaccination than that map over here on the left. So just a couple of important comments related to that context. Many healthcare for the homeless programs have multiple funding streams. They're not exclusively seeing people experiencing homelessness. So some of that population is likely falling into other priority groups, even at health centers where they are predominantly serving people experiencing homelessness. Some of their folks may fall into an age bracket or a health condition priority group that is accessing the vaccine. And so they will be reporting vaccinations, even though maybe the overall group isn't having access to it. I think we also have heard in a lot of our conversations with providers that it has been difficult to access the vaccine or trying to understand kind of where folks fall in. I know that in talking even just with friends and family members, kind of trying to understand when you are eligible for the vaccine can be challenging. So trying to figure that out for other people that you're serving can also be difficult. So figuring out when folks are eligible, encouraging their community to prioritize people experiencing homelessness can be difficult. We're hoping that this will shift a little bit in the next few weeks as more people become eligible, especially in light of the approval of the Johnson & Johnson vaccine. But just keep kind of this context in mind as Hugo runs through the next couple of slides with you.
Thank you, Lauryn. And on top of that, this data is about a month old. So as of now, we should be updating our data within the next week to get a more clear representation of what states are looking like when it comes to vaccination status. But as of now, this data is current all the way up until the end of January. And this graph in particular is actually ordered by vaccination series completion rate. And what I found really is that Alaska had the most completed series. The state also accounts for only one health center. 1,762 patients received the first dose, while another 1,669 received the second. And they had the highest completion rate by far of nearly 60%. California, on the other hand, had the most 330H health centers giving out vaccines, 29 respectively, but did not have strong showings in following up in that second vaccine. For the first vaccine, they distributed nearly 40,000, but only 5 individuals received the second dose. The state of New York gave out the most second dose vaccines, and they distributed about 1,600. States that aren't listed here are going to be South Dakota, Arkansas, Hawaii, New Hampshire, Wyoming, Arizona, Minnesota, Nebraska, North Dakota, and West Virginia. Thank you. Overall, 134,912 first dose vaccines have been administered as of the end of January, and 5,227 second doses were followed up on. That accounts for about 4% of the entire population being completely vaccinated. Here we can see the distribution of race when it comes to vaccines. And despite having the lowest positivity rate throughout the entire past year, whites did receive more than 58% of all the initial vaccines. Asians, Americans, and African Americans received about 11% apiece. Multiracial individuals received 3% of all first doses, while Native Hawaiians, other Pacific Islanders, and American Indian and Alaska Natives, despite their really high positivity rates, received less than 1% of all available doses. Out of all the vaccines distributed, nearly 60% of all vaccines went to non-Hispanics, while 23% who received a vaccine were Hispanic. And what I really want to hammer in home is that this is highlighting a further racial inequality that is not only in testing or in our positivity rates, but it's also extending into our vaccination protocols.
So if you only remember a couple of things that we said, one is that we really need to look at our data and consider the disparities to assess our progress so far and see if we have to adapt how we're offering testing and vaccination to folks. And this, I think, really emphasizes the point of meeting folks where they are and offering clinic-based options for folks who may be proactively seeking that out, but also community-based options. And ensuring that people don't have to figure out how to get to a clinic to access testing or vaccination. As we talked about, there's some states where vaccines are rolling out. Some locations it seems to be doing well. When we look at kind of the vaccination rates for certain health centers, we're seeing that they're vaccinating larger groups of people of color. Others are not doing as well. And some of this also has to do with who has access and where states are in the prioritization process too. So we're starting out okay, there's definitely room for growth. And we really want you to be involved in sharing this information. If Again, if you have held a community-based universal testing event, universal COVID vaccination event, universal flu vaccination event, please enter your data here. If you know somebody who has this information, share the link. We would love to be able to highlight the work that you're doing and really share a more in-depth story. I can post this link in the chat as well, but for now, we will wrap it up and hand it over. Thanks so much.
Thank you.
Thanks, Hugo and Lauryn. I just want to remind you as we're transitioning to our last presentation that you can submit questions in the Q&A section of your screen, and please do so as those questions come up. So our final speaker is Rachel from the University of Washington, and Rachel, over to you.
Thank you. Well, I am excited to be here with you to talk about a study I've been involved with, evaluating the impact of hotels as non-congregate emergency shelters. And here we go. So immediately following the COVID-19 outbreak, King County, which is the county that includes Seattle, moved over 700 people out of shelters into hotels. And the primary purpose of this intervention, as I'm sure you're familiar, was public health and safety. We know the dangers of being in congregate dense environments and trying to reduce the COVID risk for those in shelters. So we had in our community a remarkable effort by government and service providers to move quickly and collaborate to make these moves happen. And I've been privileged to be part of this great research collaboration between University of Washington and King County evaluation staff with some rapid response from our funders. A little bit about our study. It is a mixed method study. So we include both quantitative and qualitative data. The quantitative data came from administrative data sets. So the Homelessness Management Information System, Washington Disease Reporting Systems, and some 911 emergency dispatch. And then we did interviews with hotel shelter guests as well as staff from the providers as well as the city and county who were involved with implementing this intervention. The goal here was to create findings that would be used to assess the intervention and to inform future responses to homelessness. Now, something I want to clarify up front, our study happened really in the first half of the pandemic. So this intervention was very quick and we were quickly responding with our research, and all of the data that we collected finished by the end of August. So we are thinking about doing some updates, but as you look at the study and what we considered at this point, it's really what we now consider the first half of the pandemic, although while we were doing it, had no idea that we would still be in this state in March. A quick overview of King County's shelter system. It has over 5,000 beds and 112 programs. Over 25,000 households were served in the year before the pandemic, and similarly, in about an 86% utilization rate. So we do have a large population of folks experiencing homelessness in the King County region in King County, and have a robust emergency shelter system pre-existing the pandemic. When the when we first became aware of COVID, there was a lot of attention on how to improve safety in the shelter system overall. And so the shelter system underwent a process of de-intensification, which is, I think, more like de-densification. So trying to think about how to create safer environments. And so what we really looked at primarily in the study were these 6 leased hotels that were really the transition of pre-existing congregate shelters to hotel spaces. So the staff from the shelters moved to the hotels with the clients and included on-site 24/7 access, case management, and access to other services. Now, there was also a change in the remaining congregate shelter sites to improve access, and many of them moving to 24/7 access, as well as just reducing the density and allowing for increased increased spacing, social distancing. And then there also has been additional transformation of some individual hoteling, and that's outside the context of our study, but there have been some instances of moving individuals from congregate settings into hotels without that sort of shelter context and 24-hour staff. So for our study, the quantitative analysis used 3 different study groups. Those who were moved to the group hotels where they have private room, private bathroom, 24/7 access and on-site case management. And then the more traditional shelter system moved into these 2 different designations, which were pre-existing before the before the pandemic, although we saw some shifts in terms of the services that were being provided in some of the enhanced and basic shelters in terms of the de-intensification. So in the enhanced congregate shelter, the main difference is the on-site case management and the greater access to services. Now, the first finding that I want to share with you is that the de-intensification process was in fact associated with fewer cluster outbreaks of COVID-19 within the hotel group compared to the enhanced shelter group. And it's a good reminder as we especially get into some of the other findings that were really exciting, that the purpose of this intervention was to prevent outbreaks. And looking at the health data, we do in fact see that there were fewer clusters associated with outbreaks within the hotel group compared to the shelter groups. As I mentioned before, the chart you're looking at, these data go through the end of August. So we are looking at updating it. But from what we've seen so far, it seems that since that time, there's more reflection of what's happening in the community. So some increases as we had that big spike towards the end of the year. But these trends hold true, that those in hotels are at lower risk of COVID outbreaks than those who remained in these shelter locations. Now, what was really exciting about this study was, yes, lowering the risk of COVID, but some of the other findings that we found, which was that the intervention, moving folks to hotels, provided additional favorable health and well-being outcomes. So, I'm going to take you through a few of these different findings. The first one is we found in talking with both the staff and those staying at the hotels an increased feelings of stability associated with access to private room. So I'll be sharing a few quotes from some of the clients. It's a little bit of stability. It's something to build on, a foundation that's not sand or quicksand. Just with the shelter, it's always so chaotic. You never know, you don't know day to day that I'm going to be able to try to figure out whether you can plan on something a week from now. And another person said, it has helped to reestablish my self-esteem and dignity. So immediately seeing that for the guests staying in hotels, a lot changed beyond just the COVID exposure. We heard a lot about improved health and well-being. So one person said, my mental health has vastly improved. My physical health has improved. I'm sleeping regularly. I'm not sick right now. So as we know, folks experiencing homelessness generally don't have the best opportunity to take care of their physical and mental health. And this intervention offered more opportunities for that. Another quote, you're at peace. You're more at peace with yourself. You're in tune to your inner self. You're relaxed. You feel, quote, the water has finally drained off my shoulders, or whatever. It just feels good. It feels real good. We also heard about reduced interpersonal conflict, and we heard this both from the clients as well as the staff. Yes, everyone gets along much better. We're much more tolerant. Outbursts are few and far between. We all get along. There's a sense of unity, I think, that we didn't have before. And asking specifically about conflict, it's non-existent here. There's no conflict here. Yeah, this is nice. And what we heard from staff was really just having the opportunity for when there were tense situations or when folks were experiencing the potential for conflict, having the opportunity to kind of retreat to their own personal space and be able to create distance proactively rather reactively was really important. When we looked at the Seattle Fire 911 calls, we saw that this reflected that feeling of reduced conflict. And so the what this graph shows is the Seattle Fire 911 emergency dispatch at key locations associated with one of the providers and their congregate shelter locations, and then their move to the hotel shelter following in April. So you can see there's a few different shelters at play. Some of this reflects in the early months some initial experimentation with trying to find the right sites. But what we clearly see is that the same population, those experiencing homelessness in the CCS shelter site, when moved to the hotels, as well as de-intensifying the congregate shelter location, seeing overall a reduction in the need for Seattle Fire 911 emergency dispatch. We also heard about increased focus on the future, including housing, employment, and education. So this one person says, I'm starting to get my dreams back. You get to the point when you're homeless, you don't even care. You don't think about even why I'm going to get a place. You're gonna say, I'm out here, that's that. Now I've been in here, and I'm like, yeah, I wanna get my own place again. Having that time and space to think about what the future looks like rather than the day-to-day. We also saw in the data higher exits to permanent housing and more engagement with homeless housing services. Now, I want to emphasize no one on the research team or part of the system thinks that shelters are primarily here for providing permanent housing, and yet it is a strong goal of the staff to help folks access housing whenever they have the opportunity to. And what we saw is that those in the hotels were able to, a higher proportion of those in the hotel group, when they left the hotel, they were exiting to permanent housing, and fewer exiting to unknown locations. And what we really think this reflects is higher engagement with the staff and more ability to connect with the staff in the shelter locations and the hotel locations to access better housing when they exit, as well as just communicate about their plans. Now, the last thing we want to emphasize are the features of the intervention that we believe helped produce the favorable results. And the focus here is that we don't know what the future for congregate shelters looks like, and it may not be that a hotel specifically is necessary to achieve some of these outcomes. And yet thinking about how these specific features, whether one or some or all of them, may be able to be better incorporated into shelter environments, we expect would have a positive impact on those who are staying in the shelter spaces. So designated personal space, including a bed and bathroom that are private, security procedures to keep residents safe, such as guards and locks. We were actually surprised that some of the security measures that had been put in place to appease the larger community, we actually heard from our interviewees about how they helped the residents feel safer. Consistent access to food and having the food provided in the hotel location, in the shelter location. Storage, safe storage of personal belongings, so one didn't have to bring all their belongings with them if they left the shelter environment. And 24/7 access, which allowed for greater autonomy and time, not spending all this time in transition, moving from one place to another in the pre-COVID era, where many of the shelters closed their doors in the morning and didn't reopen until nighttime. So in conclusion, we hope that our research helps inform future decision-making in our county, and we've already been in discussion with policymakers who are moving ahead with additional hotel sites. Identify intervention features, again, that I mentioned that could be incorporated into the shelter system more broadly, and of course, contribute to broader policy conversations on this topic. We have a full report that is available at regionalhomelesssystem.org. And just want to acknowledge our funders, as well as the interviewees from city, county service providers, and those in the shelters and hotels. And finally, I'm part of a big research team from University of Washington and King County evaluation staff. And I look forward to your questions. Thanks.
Thanks, Rachel. So maybe we should begin the conversation with an issue that shades of it were in a couple of different presentations, which is the difference between the types of vaccinations that are available. Obviously, Johnson & Johnson has a one-shot version, and then there are two-shot versions. I'm curious, Margot, your thoughts on that, and then also healthcare for the homeless. There seems to be some wide variations on places that are able to do the two shots effectively as versus not. Yeah, maybe we could just continue that conversation and any thoughts there about what communities should be thinking about the different options and how to proceed.
Yeah, I mean, I think, you know, like everything else in our healthcare system and in our country, the vaccine rollout has been absolutely marked by all of the racism that we see everywhere and all of the inequities. And, you know, what you see is like communities have the least risk of COVID are getting the most vaccines and vice versa. So it sounds really bad to then say, oh, we should offer the one vaccine version to people who are homeless and the two vaccine version to other people. My honest to goodness read of the data is if it were my family member, I would just choose a coin. I don't think that there's clear data that the one vaccine is you know, worse. Now it could be, like we could wind up with more information later. And they are certainly studying a second vaccine and whether a booster would help with longevity. When you look at the 28-day outcomes of the adenovirus-based vaccine, that I hate using drug company names, that I've never used drug company names as much as I've used in the last few months because I don't know what else to call it. But when you look at the adenovirus-based vaccine, which is the Johnson & Johnson version, at 28 days, there are 0 hospitalizations and 0 deaths. And to be honest, we have no data on any of these vaccines of what they will do to things like long COVID or, you know, or like long-term effectiveness of other symptoms, although we truly believe that they should reduce all of the other long-term things. But I mean, I know that the health system has been sort of yelled at like, oh, all we care about is hospitalizations and death, because what about all these other symptoms? Although these other symptoms sort of go with those, and the outcomes look really, really, really good. My husband has a chronic illness, but he's way down on that. Like he's actually at high risk, but way down in the progressive. If someone offered me a J&J vaccine for him, I would be thrilled for him to get it. That said, the optics are bad and there's a lot we don't know. We have actually been using the other vaccines longer right now because this has all happened so quickly that we've been using the other vaccines longer. And so like we've had many more millions of people. I think that the message should be that we should use whatever we can get our hands on quickly, because I actually think quickly counts more than anything else. I think with all of the vaccines, after 3 to 4 weeks of the first vaccine, people have a pretty high level of protection. If I were to only get one vaccine at this point, based on the data, if I knew for some reason I could only get one, I would probably choose a J&J because the one vaccine data from that is probably better than the one vaccine data from the others. I don't think that we should exclusively use you know, the J&J, because I think we should try to use whatever we can. But I think that if they were populations that you were most concerned would be unlikely to come back for the second vaccine, and you had like a tranche of both, I would probably use the J&J because I think one vaccine of that is probably better than one vaccine of the others based on what we know now. In a few months, we're going to find out if they're going to recommend a later on booster of the J&J, at which point, like, we would then go back and try to find people. But to be honest, I think we should use whatever we can get our hands on. And the big fight I'm having in California is, despite it looking better, like in San Francisco, we haven't gotten permission yet, although there was a meeting that I missed this morning as I was in here to decide. We haven't really gotten permission yet to use vaccine in anyone who's basically just because they're homeless, which I personally think we should be. So that's where my mind is focused. I think the optics are bad. I think the messaging about the vaccines was really confusing. I think that the data, they're pretty darn equivalent, and that 0 is a really nice number. No hospitalizations and no deaths across all of the studies, which is what we want to hear.
So So Hugo and Lauren, do you have any insights on like the differences between those communities that were able to effectively um, do the two and the ones that weren't?
Yeah, I think part of it is going to be looking at what we get in the February and March data and looking at where folks were in the vaccine rollout plan. Because if folks were vaccinated towards the end of January, they wouldn't have needed that second vaccination yet. So I think some of it is going to be looking at kind of where states were in their plan during January and what we start seeing in the next couple months as we get a little bit more long-term data there. I think, Hugo, do you want to add anything? I think I saw that you were typing something in the chat box.
I actually did respond in the chat box, but I think you're absolutely right. Unfortunately, we don't have the data right now to state whether or not they received it 2 weeks prior or earlier. It's a little difficult to note who's getting the vaccination at what time, and that may actually account for such a disparity in receiving that second vaccination. And just echoing what Lauryn stated, was it also depends on state vaccination rollouts right now. Differing states are at different, are implementing different plans right now, which makes it difficult to allocate these very precious resources as well. But I am hoping that given that 4 weeks have passed and states have progressed, there will be an increase in second dose vaccinations with the new data that is actually going to be, like I said a little earlier, presentable within the next week.
Next, I'll pose a question to Rachel. Obviously, a lot of COCs have hotel and motel programs, and at least one of them, I guess, Claire, I'm not sure where Claire's from, but she's curious about how she can replicate some of your analysis. So I'm assuming that a lot of providers won't be able to fully replicate a University of Washington study, but do you have some tips about things that they might want to look at if they want to study the effectiveness of their hotel motel programs?
Sure. I mean, I think as always, partnering with the providers is really crucial. What was such a pleasure about this study is that we actually had both the providers and the staff really excited to tell their story and use I think have a more rigorous frame of a formal study to tell that. So certainly you can look up and read in the Seattle Times. There's some new media stories that also talk about this phenomenon, but I think we especially, this is my first time doing COVID era research where we did all the interviews via Zoom, and with the clients that was particularly challenging with Wi-Fi access, and we couldn't have done it without, we actually dropped off tablets from King County at the different shelter locations. And so we wouldn't have been able to do that without full partnership from the county and from the providers. But because folks were so interested in getting their story out, it didn't feel like a big burden. So I think finding, typically in research, you don't want to just find the people who most want to talk about one part of it. But I think that in such a challenging research environment, especially trying to keep distance, while we're still in a socially distanced environment, finding some providers who are interested in and dedicated to a full research process is helpful. And if you want to email me or look in the report, I'll post the report link. You can also see a little bit more about our research methods there.
So I wanted to talk a little bit more about the testing events. I know Margot noted that that there was a low incidence of positive cases in the testing that she did in her area. But it seems like there's some variation from what the Healthcare for the Homeless data tends from the Healthcare for the Homeless dashboards. So I wonder if we could get like a greater sense of what this looks like nationally. Is San Francisco unusual, or was that the case in most places that there were low incidences, or were there some places that were particularly having hardships? if you could just talk a little bit more about that.
Yeah, I mean, I think San Francisco has had some of the lowest prevalence in the community across the country throughout the pandemic. Even at our worst point, which we're just now coming off of, it wasn't nearly as bad as the rest of the country. The San Francisco Bay Area generally has done better, and community prevalence counts, right? That's probably the single best thing. I think the other thing is that we have uniformly, like we had a horrible, horrible shelter outbreak with like a major shelter with about a 75 or 80% attack rate, meaning almost everyone in the shelter got sick, got COVID early in the pandemic. And then our shelters are running at about 30%, 25 to 30% capacity right now. And the programs that Rachel mentioned, in California, we did Project Roomkey. I was really lucky to be helped write that and create that program where we have moved 15,000 to about 15,000 rooms, about 22,000 people into isolation and quarantine rooms. So basically a lot of them are in shelter in place hotels. So all the people who are 65 and older, all the people with underlying health conditions, not all, but many were able to move into live in hotels. And then we have isolation and quarantine units in many cities and areas to take people out, which I think has helped tremendously, just like Rachel showed. I do think San Francisco's done better. I do think in general, we've seen lower rates of COVID when I talk to places around the country in unsheltered settings and sheltered settings. So nothing. There's certainly been quite a few cases in some outbreaks, but not mass outbreaks that I've heard of in unsheltered settings, where in many sheltered settings in San Francisco, it just didn't happen to be when we've been doing the testing, but in San Francisco and all over the country, mass outbreaks in shelters. So there is a fair amount of circulating disease in unsheltered settings, but just not huge outbreaks.
I think it also goes back to kind of the reason that you're testing, where we were seeing folks who were doing the testing proactively had a much lower incidence rate, where I think overall it was 2 to 3% compared to some of the others where it was 7, 8, 19 at the highest. So thinking about kind of being proactive in your testing so that you can get folks into isolation and quarantine if they need it, and preventing that outbreak. So there is some variation across states, but also how proactive the community is in offering testing in congregate settings or sheltered and unsheltered populations.
100%. Because if you're comparing like people who tested because there were cases versus people who are, it's Tuesday and it's Friday, therefore we're testing you every Tuesday and Friday, you're going to see a lower percentage in the it's Tuesday, it's Friday versus, oh, someone came to the hospital, they were sick, let's go and test everyone else. In that case, you're going to expect to see a lot more cases.
Mm-hmm.
Yeah, I guess there's a related question there, because you, Healthcare for the Homeless, you presented clinical results. Should we assume that the people who came into your clinics to get tests, that they weren't feeling well, they were sick, or was there some sort of broader testing happening there?
Yeah, I think when we look at that, the difference between kind of the information we have on the community-based dashboard versus the clinic-based, we tend to think of it kind of as the proactive and reactive a little bit, in the way that folks who are accessing the clinic either are more likely to access clinic services in general, or they have a reason to go to the clinic, especially as we've seen folks maybe delay care for other reasons. So if they're presenting at a clinic or going to a lot of the healthcare for the homeless clinics and health centers in general have had either walk-up or drive-up options too. So thinking about folks who may be seeking out the testing, you may see higher rates there as well. And kind of comparing that with maybe some of the community-based, especially the proactive community-based testing.
So next I'll turn back to Rachel. So I'm sorry, let me find the question. One of the questions is that basically you described a list of positive outcomes associated with the hotel motel program as far as well-being is concerned. Were there other things that the service providers did besides provide a hotel room that was different? Did they provide other types of supplemental services or approach their work in any other way that might have also contributed to those positive outcomes?
Well, I think one of the things that is hard for us to disentangle is that while this intervention happened, the whole world changed. And so in addition to not, in addition to providing 24/7 access, which was one of the big changes, there stopped being anywhere to go because things were shut down in terms of the usual service locations, in terms of the places that people might need to go or might expect to go to access other day services. And so I think that that was both helpful and also something we need to be thoughtful about going forward. One of the things we were really interested in was, most of our shelter locations were pretty central in the downtown core and in central city areas to be accessible to services. And the hotel locations are more spread out. Some are located in city central and some of them are in some of the suburban communities. And we weren't sure what kind of impact that would have on those who were used to being in a particular location. But the reality is we were all at home, and those who were in the shelters were also at home, and those in the hotels. So we didn't actually hear much about the locational differences that that was something we were probing for and didn't hear from as much. I think for so I think that's a question for long term, if and when things return to normal. Will that be an issue with transportation or with trying to access services in different locations? But the reality is we saw higher engagement with staff, and what we heard from the providers, we talked primarily with the housing directors and those shelter directors, those in charge, but also from frontline staff, is that their jobs actually got easier because people were wanting to engage, people were around more, people were able to engage at the time that they wanted to, instead of kind of in this brief moment between kind of like getting your meal and going to bed and the normal chaotic environment. So I think that the job of providers changed in those group hotel locations, even though it wasn't, I don't know if it's something one could identify, but it wasn't just the hotels, it was also just changing the whole work environment for the staff.
Yeah, I guess it's going to be hard for them, or might be challenging to figure out how to replicate some of those situations post-pandemic. Do you know if they've started to talk about it?
Yeah, and I would guess there's folks in the audience who know more about what's happening in our specific community, but just yesterday there was a Seattle Times article about the city of Seattle looking to obtain hotels for sheltering homeless, and King County has already moved forward with purchasing with, I don't know if they're still looking for locations to purchase. But yes, I mean, I think we've seen widespread success. Now, I will note, if you're, following it locally, there's absolutely been some opposition especially in the suburban communities where the hotels are located. And, I think this is a familiar old problem we have around, where do we attribute homelessness to? And, as everyone on this call knows, we have a regional housing problem, not just a city housing problem. And so I don't know that there's an easy way around that. I mean, I think even with like what we saw in the reduced conflict and reduced 911 calls, well, certainly still in the locations of the specific individual hotel, there's more activity than there was when it was just like the occasional business traveler, right, to now have a hotel there. But when we look at it at a system level, what we're seeing is a lot of improvement. And so I think trying to make that case for a system level response as compelling as possible is really the best we can do.
So next, I want to turn to Margot just to follow up on a couple of vaccine questions. So first of all, it sounds like you were saying that communities should not wait till the Johnson & Johnson vaccine is available to start vaccinating people experiencing homelessness. I want to clarify that. And then the second one, someone was asking, like, I guess a question related to the usage of the vaccines. Can you get 2 Johnson & Johnson doses? What can you mix different types of vaccines? So we have some of those questions. I think everybody, most people are struggling to understand. from the medical
These
community.
are,
So if you could help us with those.
These are great questions. I would not wait. For instance, if I had permission to use vaccine and hands-on vaccine, I would start vaccinating. I would plan for the second dose, but you know what? There's a pretty good effectiveness of the first dose, and it may be, you know, probably the second dose anytime up to 12 weeks. So even if you're like, oh, I can't get, you know, the second dose in right at the 3-week for the Pfizer vaccine or the 4-week for the Moderna vaccine, that's okay. I would certainly, this is, you know, this disease causes death and the vaccine prevents death. And if you could get your hands on vaccine, I would use vaccine. I would, if I had like in my, you know, in my set, I had like some Johnson & Johnson and some of the mRNA-based vaccines, which all the studies have been done on 2 doses. I would prioritize the 2 doses for people who I felt more confident that I could get them back. So people in shelter-in-place hotels, people in shelters who were there for a long term, like if I had both. But to be honest, I would not wait for either. These vaccines are extraordinarily safe, and they are like so far beyond our wildest dreams effective. They're just really incredible, to be honest. Like we were hoping we would get a vaccine with like, 60 to 70% effectiveness. And we have vaccines with like basically 100% effectiveness against the things that we're most concerned about. Like if we turn COVID into a bad cold, that's okay, right? But they're really incredibly effective. So I wouldn't wait for anything. The question about mixing vaccines, basically the recommendation is no. There are some talks about whether you could mix the 2 first vaccines, the Pfizer and the Moderna. Those are both using very similar technology, very similar vaccines. There have been some reports of people starting with one and switching to the other, but I think the recommendation is not to do that. But the recommendation is now, one vaccine, you're supposed to follow the Pfizer 3 weeks and the Moderna 4 weeks, but it's pretty clear that up to 12 weeks has the same, and some people think it might even be a little better to wait a little longer. And there's actually a lot of policy debate right now of whether we should just be getting one vaccine in everyone's arm and get more people the first vaccine, because you get most of the benefit from the first vaccine. And then the question about the Johnson & Johnson second vaccine is currently being studied. So there is an active study ongoing, and we will get the results of that, I think in June or so. And it may come out that there's a benefit to getting a second vaccine. And if there is any benefit to getting the second vaccine, we should then go back and get it. It should be said, the Johnson & Johnson vaccine is super easy. Like it doesn't need any special refrigeration. One of the other 2 vaccines needs like super cold freezers and then can be in the refrigerator a week. The other one is more regular freezers. But the other 2 vaccines, the first 2 vaccines, are problematic because once you puncture the vial and start to give the vaccine, you need to actually give it in a very relatively short period of time, which makes, whereas what we know about the Johnson & Johnson vaccine is that you could give it to 3 people, and if the day ended and you didn't have another 3, you could do the other 3 the next day, which is not true with the others. So the Johnson & Johnson vaccine is just going to be an easier vaccine to use. The side effect profile we think is pretty similar. At the beginning, we were very worried about, could there be anaphylaxis or really bad allergic reactions? It's actually turned out, once we start to use it widely, to be much, much, much less badly than we feared. I mean, just as a context, it's much less than your chance of having it from, let's say, penicillin, which, we give out like candy. And so but that is why with the first 2 vaccines, we are asking people to wait for 15 minutes. If you've ever had a severe allergic reaction, to wait for 30 minutes, which is again, much harder to do. Social distancing, you need to find a place for people to wait where they're not within 6 feet of other people. So that's just a consideration. But I think we'll know in the spring if there's a benefit to giving people a second Johnson & Johnson vaccine, and then we can decide then if we go back and give it to people. But right now it's not recommended.
Okay. So we are at the end of our time together. It is 3:15 on the East Coast. Very varying times depending on where you are, but we are at 15 minutes past the hour. So I want to thank all of our speakers for being here today. This was very informative, and I see a lot of the attendees agree with me and have shared their thank yous as well. So thank you for being here, and we will make sure that we continue to discuss your work at the Alliance, and we continue to work together throughout the rest of this crisis. And also thanks to all the attendees for being here today. We love having you, and hope that you appreciated having us on your screens for a little while. Thank you.